Bismillahirrahmanirrahim. Quote for the day is: So verily with the hardship there is relief. Verily with the hardship there is relief. The topic for today's presentation is snake bite. I am Dr. Ayesha Amin, PGR of FCPS Community Medicine at Institute of Public Health, and I will be presenting this under the kind supervision of my supervisor, Professor Dr. Saira Afzal. She is the Dean of IPH Lahore. The learning outline for today's presentation is Introduction, Epidemiology, Classification of Snakes, Types of Venomous Snake, Pathophysiology of Snakebite, Clinical Presentation and Management, Complications, Prevention, Recent Updates, and Multiple Choice Questions. Learning outcome. By the end of this presentation, the participant will be able to describe the epidemiology and burden of snakebite, differentiate between major type of venomous snake, clinical features of envenomation, and prevention strategies, and to be able to answer the multiple choice questions. Introduction. A snake bite is an injury which is caused by the bite of a snake, especially a venomous snake. Snake bite is a neglected public health issue in many tropical and subtropical countries. Snake bite is recognized by WHO as a category A neglected tropical disease causing significant morbidity and mortality. Epidemiology, the global burden of snakebite. The highest burden of snakebite occur in countries where health systems are weakest and medical resources are sparse. An estimated 5.4 million people worldwide are bitten by snake each year, with 1.8 to 2.7 million cases of envenoming. In Asia, up to 2 million people are envenomed by snake each year, while in Africa there are an estimated 435,000 to 580,000 snakebite cases annually that need treatment. According around 81,410 to 137,880 people die each year because of snake bite, and around 3 times as many amputation and other permanent disabilities are caused by snake bites annually. This is the data from WHO. Burden in Pakistan. This bar chart is showing the deaths which occurred in Pakistan from the bite of venomous snake in 2019. We can see that in Southeast Asia, the highest number of deaths occur in India, which were 51,000, while in Pakistan, around 2,070 deaths were occurred because of the bite of venomous snake. This chart again is showing the death rate from venomous snake in 2019. There were an estimated 1.06 deaths per 100,000 people in Pakistan. So, who are at risk people for snake bite? Agricultural workers, farmers, harvesters, plantation workers, who are exposed during field activities, rural resident, especially those living in snake endemic regions with poor housing and limited access to health care, people working outdoors at night, including laborers, security staff, and travelers, barefoot walkers, and children. It increased the risk of accidental stepping on snake. Children have more severe envenomation due to the lower body mass. Household with poor storage practices, firewood collectors, people storing grains or goods on floor where snakes may hide, fishermen and coastal workers at risk for sea snake bite during net handling or diving, displaced population, flood, disaster, and temporary shelters increase human snake contact. Coming to the classifications of snake, snakes are broadly classified into two categories, that is venomous snake and non-venomous snake. The venomous snake, they are further classified as Elapidae, Viperidae, and Hydrophidae. The Elapidae includes cobras, krait, and coral snakes. The Viperidae family includes rustle vipers, saw-scaled vipers, and pit vipers, and Hydrophidae includes sea snakes and sea kraits, while the non-venomous snakes include phytons, rat snake, sandboas, and common grass snakes. These are the different type of snake. These are the vipers, which includes rattlesnake and copperheads, the elapids, which include cobras, krait, and coral snakes, and these are the sea snakes, which are found in marine environment. This is again the diagram which is showing the different type of snake. We can see that all of these kind of snake, whether they are cobras, crate, or vipers, they all exist in Pakistan in different provinces, including Punjab, Sindh, KP, and even in Gilgit-Baltistan, which are the hilly areas. So the snakes, they are everywhere. They are found in every province. So the type of snake bite, the snake bite is classified as either a dry bite or a wet bite. So what is a dry bite? A dry bite is a snake bite where no venom is injected into the victim. The signs of inflammation are minimal or even absent in this kind of bite, because mostly the snake attack as a defensive mechanism. So there are no systemic signs. The whole blood clotting time remains normal, and the patient does not need antivenom unless he or she develops systemic symptoms or the symptoms. While a wet bite is a bite where the venom is injected, leading to the signs of envenomation. There are obvious signs of inflammation present at the bite site. We will discuss what are the signs of envenomation at the bite site later. There are systemic symptoms are also present. The whole blood clotting time is prolonged, and a patient definitely needs an antivenom therapy if the systemic signs appears. So the type of snake venom, the snake venom is classified into four categories. The snake venom can be neurotoxic, it can be myotoxic, hemotoxic, or cytotoxic. The Allipidae family is mostly has the neurotoxic venom, while the sea snakes, they are mostly myotoxic. The Viperidae family has hemotoxic effect, while the vipers and cobras, some vipers and cobras, they have cytotoxic effect as well. So what is the pathophysiology? What does the neurotoxic venom does? It basically affects the neuromuscular junction by blocking the acetylcholine release or binding, which leads to the progressive paralysis starting with ptosis, and then there is bulbar weakness and respiratory failure, and it is mostly seen in cobras, kraits, and coral snakes. While the hemotoxic or the vasculotoxic venom basically damages the vascular endothelium and interferes with the coagulation pathways. It leads to the coagulopathy, spontaneous bleeding, shock, and capillary leak syndrome. And it is mostly seen in bristle vipers, saw-scaled vipers, and pit vipers. What does myotoxic venom does? It causes direct muscle fiber destruction, releasing myoglobin. It results in severe rhabdomyolysis, causing muscle pain, dark urine, and risk of acute kidney injury. And it is seen in sea snakes and sea kraits. The cytotoxic venom, it produces intense local tissue destruction, inflammation, and necrosis. It leads to blistering, ulceration, and gangrene, sometimes requiring debridement or amputation, and it is prominent in the bite of some cobras and vipers. Clinical features of envenomation. The local signs are there would be puncture mark at the bite site, there will be pain, swelling and redness, blistering, nausea and vomiting, difficulty in breathing, sweating. There is a dry bite, there will be no venom or minimal sign, while if it is progressive, then there will be local plus systemic signs. These are again the signs of snake bite. In case of a non-venomous snake bite, there will only be, as I said earlier, there will be minimal or no signs of inflammation present. So there can be mild swelling, color change of skin, or light bleeding. While in case of a venomous snake bite, there will be pain, puncture at wound that bleeds. There would be sweating, nausea and vomiting, headache, dizziness, and difficulty breathing. The systemic manifestation can lead to the neuroparalysis, that is ptosis, respiratory failure, prolonged whole blood clotting time, which leads to bleeding tendencies, shock, acute kidney injury, myoglobinuria, and muscle pain, which is because of the rhabdomyolysis. Management. The management is broadly classified into two aspects. There is a pre-hospital management and hospital emergency department evaluation. During the pre-hospital management, basically first aid is provided to the patient. So the first step is to stay calm. Keeping calm can help slow the spread of venom in the body. Take deep breaths to help control panic and anxiety. Move the patient to a well-ventilated area. Distance from snake if safe. Note the snake's appearance or take the picture to help the medical professionals to identify which kind of snake has bite the patient. Keep the bite area still and lowered. Try to keep the affected limb as still as possible. Use a splint or any rigid object to immobilize the limb if necessary. Apply pressure bandage to control blood flow. In case of leg bite, apply the pressure bandage above the knee, and in case of arm, apply above the elbow. Partially release pressure every 10 minutes. Prevent constriction. Remove any tight clothing, rings, or other items near the bite site that could constrict swelling tissues. Gentle cleaning. Gently wash the bite area with the soap and water to remove any venom on the snake skin. Do not scrub or apply alcohol. Position of the limb. Keep the bitten area at or below the heart level to slow the spread of venom. Call emergency services. Dial emergency services 112 or get the nearest hospital as quickly as possible. So what are the do's and don'ts in case of a snake bite? So you need to stay calm, inform an adult, leave the snake alone, limit movement and go to hospital. While do not attempt to cut the wound, do not suck the wound, do not shock or apply extreme pressures, do not apply a tourniquet, and do not go to a traditional healer. So once the patient has arrived in the hospital, it's basically treated as an emergency, and the patient is evaluated. So the protocol is followed as ABCDE rapid assessment. The airway is checked for drooling, inability to swallow, impending respiratory failure in neurotoxic bites, breathing, assess the respiratory rate, effort, oxygen saturation, and look for paralysis or fatigue. Circulation, check pulse, BP, capillary refill, identify shock or bleeding, star oxygen, IV access, and isotonic fluids and blood if the patient is severely hypotensive. Disability, assess mental status and early neurological signs, that is ptosis and cranial nerve involvement. Exposure, inspect the bite site. PODS is basically stands for puncture, oozing, discoloration, and swelling progression at the bite site and any bleeding. Do not apply tourniquets. Control severe pain. Try to avoid NSAIDs due to the risk of bleeding, and remove pressure bandage if it was applied previously. Monitor the vitals of the patient, that is heart rate, blood pressure, respiratory rate, oxygen saturation, temperature at frequent intervals, urine output to detect early acute kidney injury or myoglobinuria. The key investigation which are needed are 20-minute whole blood clotting test, PT-INR, fibrinogen, platelet count, creatinine and electrolytes, creatinine kinase, and urine myoglobin. The definite therapy for venomous snake bite is antivenom therapy. The anti-snake venom serum is a sterile preparation which is mostly polyvalent, containing purified and concentrated immunoglobulins obtained from the serum of healthy horses immunized against the venom of the following 4 common poisonous snakes which are found in Pakistan, namely cobra, krait, bristle vipers, and saw-scaled vipers. Indications for the use of antivenom: if there are signs of neurotoxicity, that is ptosis, ophthalmoplegia, respiratory muscle paralysis, signs of hemotoxic signs of hemotoxicity, prolonged 20-minute whole blood clotting time, raised PT-INR leading to spontaneous bleeding from gums, hematuria, or epistaxis, or DIC-like picture. If there are signs of local inflammation, rapidly progressing swelling, extensive bruising or necrosis, or there are signs of systemic toxicity, which are hypotension, shock, or acute kidney injury. So what is the vial and dosage of the antivenom? Anti-snake venom is supplied as a 10 ml liquid in glass vial. The product is potent for 2 years from the date of manufacturing if kept at 2 to 8 degrees centigrade. Room temperature deteriorates the protein content of anti-snake venom serum. Conventionally, the dose of anti-snake venom serum is 10 to 30 ml. In severe cases, it may go up to 200 ml. 1/3 of the initial dose can be administered locally around the wound, and remaining 2/3 of the dose intravenously. The second dose can be repeated 2 hours after the first dose or even earlier, depending upon the condition of the patient and severity of the symptom. Further dose can be repeated after 6-hour intervals until the symptoms disappear completely. So the management is how to infuse the anti-snake venom serum. Dilute the required dose in the normal saline, 100 to 200 ml of normal saline. Give intravenously over 1 hour. Administered in a monitored setting due to the risk of anaphylaxis. Prepare adrenaline 1 ml into 1 ml is to 1,000 solution ratio subcutaneously to be administered in case of an unfortunate allergic reaction. The supportive care includes respiratory support, which is mechanical ventilation for neuroparalysis, fluid therapy, avoid fluid overload, monitor urine output. Blood products which are needed can be FFPs, that is fresh frozen plasma, and cryoprecipitate for coagulopathy and analgesia. Avoid NSAIDs and opioids are preferred in case of severe pain. Complications of snakebite, there can be local and systemic complications. The local complications are tissue necrosis and gangrene, and in rare cases, it can even lead to the compartment syndrome. The systemic complications are neuroparalysis, shock, acute kidney injury, and multi-organ failure, while the treatment-related complications are allergic reaction, serum sickness, and fluid overload. Prevention strategies. The primary prevention includes personal protective measures, which include wear boots and long clothing when walking in fields or forest. Avoid walking barefoot, especially at night. Use torch, flashlights during nighttime outdoor activity. Avoid putting hands or feet into the holes, crevices, or tall grass without checking. Environmental measure: keep residential areas clean, remove debris, wood piles, and rodent habitats. Fill cracks in walls and floors. Keep grass and shrubs trimmed near home. Proper storage of firewoods and grains to reduce snake attraction. Lighten pathway to at night in rural homes or schools. Behavioral measure: educate children and villagers about snake bite, snake habitats, and its behavior. Avoid provoking or handling snake. Do not attempt to kill or catch snake without expertise. Community awareness: inform villagers of nearest equipped health facilities. Train community health worker in first aid and referral. These are all the primary prevention measures. The secondary prevention, which include first aid measures: immobilize the affected limb with a splint, keep victim calm and still to slow venom spread, and transport immediately to the nearest healthcare facility. Try not to use tourniquets, no incision or suction at the bite site, no hermal remedies, ice packs, or harmful traditional practices should be done. Tertiary prevention, which basically focuses on rehabilitation and to avoid complication, early administration of antivenom and supportive care, monitoring and early treatment of complications, that is acute kidney injury, coagulopathy, or neuroparalysis, wound care and rehabilitation for tissue necrosis, and psychological support for trauma or anxiety after severe envenomation. Recent update. This is an article which was published in March 2025. It stated that it was a comprehensive review on the recent advances in the use of ethnomedicinal plants and their metabolite in snake bite treatment. So they observed that there are many plants which are basically can be used as a treatment of snake bite. They revealed that there are 39% of herb, 38% of shrubs, 18% of trees, 2% of climbers, 2% of bulbs, and 1% of ferns have snake antivenom potential, which is indicative of the presence of numerous phytochemicals such as alkaloids, coumarins, curcuminoids, flavonoids, steroids, triterpenoids, and cinnamic acid in particular plants. They identify following plants like pineapple, papaya, and turmeric, which have these metabolites, and they can be used. Their extract basically can be used in the formation of snake bite treatment. This is another article which states that the broad spectrum antivenom could revolutionize treatment of venomous snake bites in Africa. So what they did in this study, they basically develop antivenom that does not require us to constantly extract antibodies from animals. Basically, the polyvalent anti-snake venom, it is extracted, it is injected into the horse, and then the antibodies are made. While in this technology, what they use the phage display technology to develop or antivenom. This method makes it possible to select and copy effective antibody fragments that are basically nanobodies, and they are later produced them on large scale and with consistent qualities. So researchers have now developed sorry. So the researchers have now developed the treatment effective venom by combining 8 carefully selected antibodies into a cocktail that targets venom from 18 medically relevant and African snake species. Nanobodies, they are basically a special type of antibodies that originate from the antibodies found in animals in the camel families, basically camel llamas. And nanobodies are both smaller and more stable than ordinary antibodies. The researcher developed these nano antibodies to bind strongly and precisely to many different similar toxins, which enables the antivenom to neutralize venom from multiple species. However, this study is basically done in vivo, and it has shown promising result and covered a wide spectrum of snake species, increasing its potential for effective treatment in real life cases. An experiment where the antivenom was mixed directly with the venom before being injected, it has successfully neutralized venom from 17 out of 18 tested different snake species, with the exception of one of the green mambas. So it is the trials have been taken in animals, but it's not being tested in humans. Coming to the multiple choice questions. The first MCQ is a 32-year-old farmer arrives 2 hours after a bite on his foot. WBCT count, that is whole blood clotting time, remains unclotted at 20 minutes, and swelling is rapidly progressing up the leg despite of the initial dose of antivenom. What is the most appropriate next step? A. Repeat WBCT after 6 hours. B. Send for coagulation profile before repeating antivenom. C. Start prophylactic antibiotics. D. Apply a tourniquet to stop venom spread. E. Immediately give an additional full dose of antivenom.
E.
Yes, E is the right answer. The second MCQ is an emergency department notes increasing snakebite death despite adequate antivenom supply. Analysis shows most deaths occur before patient reach the hospital. Which public health intervention would most effectively reduce mortality? A. Establish village level transport and referral system. B. Conduct hospital based CME for doctors, increased antivenom stock. D. Start weekly snake removal campaigns. E. Provide free analgesics to community.
D.
No, the right answer is A, establish village level transport and referral symptoms. Uh, because the patient has already received the antivenom therapy, but the patient is reaching late to the hospitals. Third MCQ is a 12-year-old boy is bitten by the suspected neurotoxic snake. He reached hospital within 30 minutes. At arrival, the vitals are normal, but he develops mild doses after 20 minutes. Which interpretation is most accurate? A. Observation only, no antivenom needed yet. B. Ptosis is due to anxiety. C. Repeat WBCT before deciding. D. Early neurotoxicity, initiate antivenom immediately. E. Begin antibiotics before antivenom.
D.
Yes, D is the right answer. These are the signs of neurotoxicity. That is, the patient has developed ptosis. The fourth MCQ is a patient presents 5 hours after a viper bite. WBCT is normal, but the patient has massive local swelling, blistering, and severe pain. What is the most likely explanation? A. Dry bite. B. Non-venomous bite. C. Local envenomation with inadequate systemic spread. D. Infection rather than envenomation. E. Incorrect WBCT technique.
C.
No, there are the right answer is C, because there are local envenomation and the systemic signs are not established yet. The fifth MCQ is a 45-year-old man presents with the sign of neurotoxic envenomation after receiving the recommended antivenom dose. Paralysis continue to worsen. What is the most appropriate next intervention? A. Give additional antivenom and observe. B. Provide early mechanical ventilation. C. Start IV antibiotics. D. Wait another hour for antivenom to act. E. Perform fasciotomy.
A.
No, the right answer is B, because even after receiving the recommended antivenom dose, the patient's paralysis is continue to worsen, which can even lead to the respiratory paralysis. So the patient needs early mechanical ventilation. Sixth, a patient arrives 3 hours after a Russell viper bite and with hypotension, cold calamities, and oliguria. WBCT is prolonged. After first antivenom dose, BP remain low. What is the most crucial next step? A. Repeat antivenom immediately. B. Start antihistamine. C. Start vasopressor and aggressive fluid therapy. D. Take the patient for dialysis immediately. E. Observe for 2 hours.
C.
Yes, C is the right answer as the patient has low BP, so we need to
Why did you do it like this?
vasopressor and aggressive fluid resuscitation. The seventh MCQ is a 28-year-old farmer is brought with a history of snake bite 45 minutes ago. He has bleeding from gums and persistent oozing from the bite site. WBCT is prolonged. The nearest hospital has limited antivenom stocks. Which triage decision is most appropriate? A. Wait for confirmatory lab test. B. Start IV fluids and transfer without antivenom. C. Give tetanus toxide only. D. Administer available antivenom dose immediately before transfer. E. Apply tight compression above the bite.
B.
No, the right answer is D. As the patient has taken the antivenom dose, but we need to give the patient, sorry, the hospital has the limited stock of antivenom, but still we need to administer the patient antivenom before the referral. 8. An evaluation team is reviewing snake bite prevention programs. The community had awareness sessions, but incident did not decline. Field visits revealed most workers continue harvesting crops barefoot. What was the most likely failure in the program? A. Posters were not colorful. B. Knowledge improved, but behavioral change was not ensured. C. Antivenom supply was inadequate. D. Snake population increased. E. Sessions were conducted by nurses instead of doctors.
A.
No, the right answer is B. The community is aware, they had knowledge, but their behavior has not changed. The ninth MCQ is a district health department plans to reduce snake bite mortality. Surveillance data show most deaths occur in transit due to delayed transport. Which public health intervention would provide the highest impact? A. Increasing antivenom stock at tertiary hospitals. B. Strengthening ambulance and referral network in villages. C. Training more ICU staff. D. Creating a snake species identification center. E. Monthly awareness seminar at district health quarter hospitals.
B.
Yes, B is the right answer as there is a transport delay. So we need to strengthen the ambulances and referral networks. The last MCQ is a government aim to include snakebite in its national notifiable disease list. What is the most important expected public health benefit of this policy? A. Identified snake species accurately. B. Increasing the number of venom labs. C. Reducing the need for awareness campaign. D. Increasing production of antivenom automatically. E. Ensuring timely reporting and targeted resource allocation.
E.
Yes, E is the right answer. This is the key to MCQs. These are the references which have been used in the presentation. This is the official channel of the Institute of Public Health Lahore where this presentation will be uploaded. And thank you for listening.
Thank you so much. It was a great presentation.
Thank you, Dr. Amna.